Hello, my name is Rob Soiffer. I am a professor of medicine at Harvard Medical School and at Dana-Farber Cancer Institute in Boston. And I've had the pleasure of being the chair of the advisory committee of the CIBMTR, which is the Center for International Blood and Marrow Transplant Research. And I'm talking today about differences between transplant practices in Europe and the United States and attempts to bridge that gap. We really operate in a very similar fashion, but there are some pointed differences that are worth mentioning. The first is that the average age of a transplanted patient in the U.S. is a bit older. So generally in North America, more likely to transplant patients over the age of 60 than in Europe, and probably over the age of 70. The median age difference is about 4 to 5 years older in North America and in the U.S. In terms of approach to transplantation, there are different conditioning regimens that can be utilized in advance of transplantation. And in the U.S., it's more likely that patients will receive a myeloablative transplant, that is intense conditioning, rather than a reduced intensity transplant. And what's quite interesting is that there are a couple of prospective randomized trials, one from Europe, two from Europe actually, and one from the United States that actually have different results. In the European trial, which was largely based in Germany, suggested no real difference in outcome between reduced intensity and full intensity patients for AML. In contrast, the US prospective randomized trial from the BMT-CTN showed the opposite. In fact, myeloablative transplant patients did better in terms of a lower relapse rate and improved disease-free survival. It's important not to look at a randomized trial and just take the results blindly. You have to look at who's entered into the trial and what the conditioning regimens are. And I would say that in the European and the US trials, the conditioning regimens were very different. So both prospective trial results are probably valid, and they just looked at different things. Another difference that is quite stark is approach to GVH prophylaxis in Europe and the US. First, in terms of the calcineurin inhibitor that we predominantly use in the US, the majority of patients receive tacrolimus, whereas in Europe, the majority of patients receive cyclosporin. We do often think of these drugs as somewhat interchangeable. They're the same class of drugs, calcineurin inhibitors, but they are different and have slightly different drug interactions and toxicity profiles and efficacy. So that may have an impact on transplant outcome. One of the other major differences, and this is something that is near and dear to the heart of Dr. Kroger and myself, because both of us led trials on this issue, is the use of in vivo T cell depletion, that is with anti-thymocyte globulin or ATLG. And there was a US trial, which I was the first author on, but which was a multi-center trial, multiple sites around the country, which looked at the addition of ATLG to tacrolimus and methotrexate as GVH prophylaxis. And what was shown in that most recent trial was a reduction in chronic graft-versus-host disease, but no improvement in GVHD-free survival, specifically because of adverse effects on relapse and non-relapse mortality, worse survival. That is not at all what was observed in the trials by Dr. Finke and Dr. Kroger in unrelated and related transplants coming largely from Europe, largely from Germany, but other nations as well, where indeed an advantage was seen for patients who received ATLG or an ATG type compound. So how do we reconcile those two? I'm not completely sure. We've been looking for differences between the trials. This may be an issue of dose, and this may be an issue of pharmacodynamics, but what it's led to is really a greater reliance on ATG in Europe and a much lesser reliance here in the United States. And I think that's going to continue right now, because I'm not sure there's going to be an appetite for yet another prospective randomized trial. What's interesting about all this is that when we looked, Dr. Kroger and I had the opportunity to look at the EBMT and CBMTR database. What we found was that the non-relapse mortality of patients in Europe and the US were identical, the 3-year non-relapse mortality. And the overall survivals weren't appreciably different. So indeed, there may not be a significant impact on outcome, no matter what our differences are. I think it's certainly possible that there are intrinsic differences in transplant practice and intrinsic biological differences in the populations in North America and in Europe that may also have an impact on our approach.